how does decision making, how is that supplemented by artificial intelligence and AI can really help on the provider and the physician side of things. On the non-clinical, there is a lot of effort, of manual effort that goes into things like appealing denials, requesting prior authorizations, pre-certifications. Like there's a lot of manual work that goes into that it does have some cognitive load, but a lot of it is, hey, I've got to fill out this very specific redetermination or reconsideration request form. And that is where I've seen just primed to take over some of the busy work and let the really, really brilliant people who have spent years or decades working with payers that understand how things have to be coded, billed, how can we be more proactive in nature, instead of just filling fields in an appeal form. And that's where I think AI and some of the RPA could be really beneficial, is just supplement that workflow. Or really augment that workflow so that you click a button, it's pulling all this data and it's populating it for you.
Welcome to Medical Money Matters, the podcast where you can find experts, answers, and resources so that you can achieve mastery over the financial and business aspects of your practice.
Hello, everyone. Welcome to Medical Money Matters. I am joined today by Andrew Harding, who is a national revenue cycle expert, as well as one of the co-founders of Rivet Health, which is a software company whose purpose is to accelerate the revenue cycle for medical practices. So, Andrew, welcome. Thank you for joining me today.
Jill, thanks so much for having me.
Absolutely.
Really excited chatting with you today.
Yeah, likewise. Well, we have at Healthy Practices, we have really enjoyed the partnership with Rivet over the last several years and delighted that we have had several shared clients all across the country. So it's great fun. I appreciate the software that you and your whole team have created, and we really find Rivet to be best in class when we're looking for something to solve a problem for a client. So thank you for being in that space. Thank you for joining me today.
Greatest compliment.
Yeah. I just think the products that you all create are really intelligent. I appreciate it. It's fun to talk to clients about this. I'm curious to jump in and just have you reflect a little bit on the industry landscape and what are some of the things that caused you and your partners to get together and start this technology company?
Yeah, great. It's a great question. We've seen the industry as a whole goes through these cycles of part of it is technology makes advancements. The industry catches up to those advancements and then builds solutions and then deploys those solutions. And so just throughout my career, kind of moving from operations to consulting and then to technology, kind of rode some of those waves, did many EMR, PM system deployments and installs, and kind of saw the evolution from, hey, we want a global solution. We're making the shift from paper charts, paper records, paper claims to EMRs, PM systems. Then a lot of opportunities to optimize those systems. And then say, well, hey, they've got 1,000 things they have to worry about as a PM or an EMR. We need point solutions that are best in class for solving some of these things. And so the industry develops point solutions. Then it says, hey, we need better integration. We're going to go back to consolidation. And then we want to, the next 5 to 7 year cycle rolls around. It says, hey, we want the best point solutions because we have opportunities to optimize our revenue cycle further. So we had just seen some of those cycles manifest itself throughout healthcare and revenue cycle and wanted to kind of get ahead of the next wave of being a point solution that bolts onto your EMR and practice management system. And it's been a really fun ride. We've got, as of this date, customers in 49 of the 50 states. The running joke is we're working on Hawaii, and between me and my co-founder, Ted, one of us will go on site and we'll bear that burden to go on site in Hawaii.
You'll take one for the team. All right, listeners in Hawaii, we're going to put the link to Rivet Health in the show notes, but you all have the opportunity to help Rivet create a bingo here. So that's good.
Yeah, there we go.
And also, send Andrew to Hawaii.
Yeah, that sounds good. And part of the goal with launching Rivet was, it stems back to our founding mission statement. We wanted to power empowerment in healthcare through incomparable technology. And, obviously you think really long and hard about the mission that you want your company to drive forward, and you break apart just about every part of that phrase into what we want to do. And we look at the powering and empowerment. Even though they sound very similar, they are really different in nature, right? Think of the powering as the technology, the software side of things. But then empowerment is, we want to arm providers with the best possible data that they have to make decisions, to run their business, to help in their patient experience, their patient financial journey. And if we can empower them through really amazing, best of breed, incomparable technology, we've done our job. And, those provider relationships mean a lot to us, and enables us to continue developing and investing in product and development by listening to some of our healthcare practices. So,
yeah. I love the phrase incomparable technology. That's fantastic, and really puts a stake in the ground. Like it's going to be incomparable. I would love it if you could just wander through for us the evolution of technology as you see it that allows you to have those new, point solutions coming to market.
yeah. So, I think of it in two ways. The first is legislation that is enabling better interoperability. And the second is just overall tech landscape improving, right? And we look at the legislation, for example, like 21st Century Cures Act, that is all around interoperability, enabling unblocking of information. That's opened up pathways to have a more modern development trajectory between point solutions and host systems. The second is just as you move from many legacy on-prem systems to more cloud-based technology, the advent of APIs, FHIR interoperability, right? It moves it from legacy interfaces like HL7 and X12 to APIs and FHIR. Interoperability just enables both systems to be in this really smooth congruence where balances are settled between systems, patient demographics are updated, appointments are in line. And so it doesn't feel as painful as going out to a separate system, maybe waiting for integrations to catch up, right? Just technology's gotten so good and so fast that it can really feel like you're working in the same solution or on the same platform, even though it's two totally separate interfaces. So that improvements in interoperability have been amazing because it allows us to slot ourselves in with some major players from a partnership standpoint and just get on marketplaces to have direct connections where it's literally as fast as click a button, you're integrated, and we have data flowing through. So it's been really amazing to see just over the last, say really the last 5 years has been just a huge leap forward in interoperability between systems. And it's been kind of in that sweet spot to be able to support legacy on-prem interfaces, as well as the more modern, newer API and marketplace interfaces.
That's so fantastic. I can reflect back on having done a lot of technology implementations in medical groups throughout the 90s and the early 2000s. And I used to joke, if I had a nickel for every time a software salesperson told me there was an HL7 interface, like that was a solution to everything, I'd be retired. It's so great to hear that the APIs are making things much easier. For the uninitiated, one of my commitments in this is to try to debunk and demystify all the acronyms. So for those in our audience that don't know, could you explain the acronym API and also FHIR?
Yeah, so an API, it literally stands for the Application Programming Interface. But what it is, and if we kind of use some legacy architecture into it, or from HL7 into API, is it's really a structure of data. So if we want a specific patient record, a demographic record, an appointment record, a medical history, these are called endpoints where we say, go to Athena, AdvancedMD, NextGen, say, hey, we want this patient's information. We request it through an API call, and they serve back data in a consistent format. And so we know exactly what we're looking for, that kind of the name slots here, the date of birth slots here, phone numbers here, addresses here. So it is just it's a streamlined way to request data and get it from different PM systems. So that's what an API is. Mm-hmm. And then, same thing with FHIR, right? FHIR is a message format structure that's evolved beyond classic HL7, mm-hmm. right? HL7 stands for Health Level 7. And it really is a message format and structure, right? Two of the most common ones are ADT and SIU messages. and is more formatting, right? HL7 is very strict and rigid at what type of data in this specific segment can be sent over. So just fire an API, open that up to getting broader data sets, getting more comprehensive records so that it's not as defined as specific HL7 segments.
Got it. So if I'm the administrator of a medical group and I'm talking with someone about adding on a piece of software to our existing EMR and practice management platform, if I hear them talking about APIs and or Fire instead of HL7, then I know they're kind of next generation product.
Yeah, it's and a good way to vet potential partners is if there's an API marketplace or a partnership marketplace, is that vendor listed in that marketplace? Because then you know that you're going to have a sponsored interface by the PM or the EMR system that is not necessarily always point and click, hey, you're ready to go live, but it is simplified, it's streamlined, there's stability on both sides of it, as opposed to, an HL7 is just an industry standard, but there's no real, like, what is cost? What is timeline? You have to, in many cases, set up VPNs to connect through this. And so there's a lot more build that goes into a legacy interface versus an API, right? API, you do a lot of the front end development work, and then you recoup the rewards as you can effortlessly connect to system after system. So it's like a dead giveaway of, does this partner connect? Is it going to be a good data flow? Is there a marketplace that you can identify this as a potential partner?
Yeah. So you and I were talking earlier about this. Sort of the large marketplace out there is the Athena One marketplace, which is great.
Yep.
And that I think does, it sort of signifies some street cred
Oh.
for any group that's a part of that marketplace because they've been pretty well vetted. And you also mentioned Next Gen Marketplace. Are there others that you're aware of that you are participating?
Yeah, a lot of the major PM systems have this online marketplace, and you've got systems like Greenway, Veradigm are all scripts. Advanced MD is one. They're in our backyard. We're both headquartered in Utah. They all have API systems, and sometimes it depends. There are different versions of the specific practice management system. One might be an enterprise system that supports APIs. One might be an enterprise system that's on-prem. And when I say on-prem, like you are literally hosting your own server. You've got a closet, right? You've got a closet that nobody ever goes into except for, once a month, and you unlock it and brush the dust off. Yeah. We hope. Those on-prem servers there's a lot of maintenance costs. There's maintenance fees. There's support staff around that. And so you will see a lot of the marketplace partnerships when there is an API system. That's how they do consistent vetting. Yes, this is a partner that we work with, that we have streamlined connectivity. And some of the implications for that is those marketplace partnerships have been pre-vetted. To your point, Jill, you're like, yes, this partner is secure. They comply with our data standards. We vetted them. In some cases, there are security audits to make sure that what's being done with PHI and PII are, in a safe manner. So you have just a lot more confidence that these systems are the, kind of quote unquote right systems to be connecting with, and that there's not going to be an abuse of data or a misuse of that data once it comes from your host system to a third party vendor.
That's great advice for our audience, is just if you're looking at products to add on to your system, have the, be aware of any that don't appear in your vendor's marketplace. That's, a little sketchier as they go. Well, that's a good segue to ask you for your perspective on new technologies that you see. Everybody's talking about AI and machine learning. How do you see those coming and impacting the market?
Yeah, it's a fun time to be alive.
It is.
Right. There's, this
ChatGPT is your friend, right? Yeah.
Yeah. The pace at which technology is doubling and improving in functionality and in capabilities is just, it's obviously faster than ever, and it's incredibly impressive. And, you look at certain things like machine learning, RPA, robotic process automation, and AI, and how that's deployed in systems. I'll look specifically at AI and some of the RPA components. There's clinical and non-clinical, right? I'll focus a little bit more on the non-clinical because that's where Rivet spends a lot of its time. But on the clinical side of things, in care coordination, clinical like pathways, how does decision making, how is that supplemented by artificial intelligence and AI, can really help on the provider and the physician side of things. On the non-clinical, there is a lot of effort, of manual effort that goes into things like appealing denials, requesting prior authorizations, pre-certifications. Like there's a lot of manual work that goes into that it does have some cognitive load, but a lot of it is, hey, I've got to fill out this very specific redetermination or reconsideration request form. And that is where I've seen it just prime to take over some of the busy work and let the really, really brilliant people who have spent years or decades working with payers that understand how things have to be coded, billed, how can we be more proactive in nature, instead of just filling fields in an appeal form. And that's where I think AI and some of the RPA can be really beneficial, is just supplement that workflow. Or really augment that workflow so that you click a button, it's pulling all this data and it's populating it for you. Same thing with some of the forecasting. We have a product that's all around forecasting out your net revenue, where we use some of those machine learning models and linear regression models to forecast out timing of cash and realization of your net revenue. And those are just, it's technology that a decade ago didn't exist. So we couldn't have built these advanced models. And now we can deploy these models that helps with cleaning up your month-end process, taking it from 5 to 10 days to 5 to 10 minutes. And that type of technology just augments your team's workflow such that it is a lot less manual work and they are spent doing the higher leverage activities. So that's kind of what we've seen, some of these successful deployments of this technology.
Yeah. Well, and that's one of the things I hear frequently from leaders and medical groups, physicians and administrators, is just the rise in the amount of the busy work, and you got to jump through these 5 more hoops in order to get paid. Yeah, I love thinking about ways to apply, AI and any kind of automation to those kinds of things to streamline. So that's a really great opportunity for us to focus in a little bit. And I want to ask you what might seem like a little bit of a silly question, but I think for our audience will appreciate it. And that is, speaking to our physician owners, why should they care about denials?
Denials are just, it's like any service. Imagine that you spend time, money, resources, and you get zero. And it's not even like it's a charitable contribution. This is, that is a write-off. It ends in, a non-elective charitable donation. And we look at just the impact of denials is they range, right? You might have, a $50, $100 denial, but you might have thousands or tens of thousands of a single denial. And that's just on the physician side of things, right? It can be hundreds of thousands of dollars on the hospital and health system side of things. And it is a $0 margin service at that point, where as a provider, you are taking time, you are taking an exam room, a clinical room, you're taking resources from your schedulers, your registration staff, the overhead from a practice, the rent that you pay. And then at the end of it, you're actually underwater because you've rendered services, you've paid your non-clinical support FTEs, as well as your own time as a physician owner, and you get nothing in return. So it hurts profitability, it hurts margin. You literally pay to get nothing in return. And the truth about denials is so many of them can be appealed. And it's the additional time and effort that goes in is typically kind of well spent, given the monetary value of going from zero to something.
Yeah.
And that's where we think denials can be so negatively impactful for the operating margin, the profitability, the ability to be an independent provider, run your own practice. Is at the end of the day, you have to have a profitable operating margin to stay as an independent provider. And the more appeals that you can successfully have overturned, the more corrected claims. And from a preventive nature and being more proactive in how do I avoid these in the first place, right? Creating bill edits, stopping kind of dirty claims before they go out the door. It's going to pay off in spades, given that you are not spending rework costs. You get paid faster. The difference between a clean claim and a claim that requires appeal, right? Generally, the average adjudication cycle is about 20 days from when you submit a bill to when you get a remit. Add in, if you have to appeal that jumps from about 20 days to about 75 days. And because you're not only identifying that denial, prioritizing that denial, working that denial, rebilling it, appealing it, sending a corrected claim, but then the payer is also, they have a lot more manual steps once that appeal comes through. And so it jumps from 20 days to 75 days. And that's they had pretty basic math that's almost 2 months in cash delay that can be really impactful when you're talking about paying bills, paying rent, FTEs, salaries. So the acceleration of cash can be really beneficial. And that's where I think about proactively resolving or eliminating these denials can have a, very strong multiplier effect.
Yeah, absolutely. Well, the most groups, and as we go in and start work with a group on their RCM, we frequently find those clean claim rates in the 80%, and that just makes me shudder. So for our audience, we're generally looking at the key performance indicators for RCM as, moderately good performance would be to be above 90% on the clean claims rate. We like to push it into the high 90%, but that still leaves 10% of the claims potentially at risk for not getting paid. That's frequently conversation that we're in with physicians about why they should care about denials. And as you and I were talking, I'm kind of surprised with even the top drawer practice management systems that are out there today. Many of them fall short on organizing denials and giving any real good intelligence back to the practice. So that's one of the reasons why we really appreciate the work with you and the denials tool that Rivet has, which is it gives some pretty incredible, actionable intelligence to the practice about why claims are getting denied so we can work on some prevention, bringing that down.
Well, and
it's surprising missing in a lot of systems.
Yeah. And typically what we see when we come into those systems and start working with existing, maybe they have work queues built where it says, this is at least the scope of services that I'm supposed to be appealing, rebilling. It's at least filtered that way. What oftentimes is lacking, and going back to one of the points we were just talking about, which is using AI and some of the RPA in the workflow and identification, is we know that 70 to 80% of denials should get appealed, should get paid when they get appealed or rebilled as a corrected claim pretty effortlessly. On top of that, right, you might have level 2 appeals or P2P or more advanced clinical appeals, but that's definitely the minority. And so when you've got a system that just says, hey, here's the kitchen sink of denials. You've got 500 things in your queue. You could work any single thing that you want. There's no real rhyme or reason. Maybe you sort it by high dollar. Maybe you sort it by ones that are approaching timely appeal windows. But there's really not a whole lot of intelligence that goes into not only synergistically working these denials, like, hey, can you work more than one simultaneously? How do you automate some of these steps? But also, what are the ones that you should be working? How do you prioritize these so that you're getting, if you only have 8 hours in a day, how are you making sure that those 8 hours are the best spent from an ROI standpoint? And that's where we just see there's a lot of gaps in existing systems is they give you the queue, but it's everything. It's right. It's just kind of spits it out there as to every single denial that you could possibly work with no rhyme or reason into what you should be doing and when you should be doing it for those specific denials. And that's where the intelligence can come through. What are the highest likelihood to be appealed? What are the processes that you should be automating? If you have 10 denials for Medicare for this exact same procedure code with modifier, I'm going to do the same thing 10 times in a row. Well, do those congruently, right? Why not align on basically I am creating these 10 appeals and I'm doing it in a batch as opposed to one at a time.
Right.
So that's where we've just seen some of the RPA and AI being really beneficial on the back end denials follow-up process.
Yeah, absolutely. Well, and again, like you said, it's kind of a puzzle why that sort of kitchen sink approach is really where most systems default to. And I laugh and I say, well, probably because most of the practice management software systems didn't actually have a person that understands billing helping with their designs. Your team has done a great job.
And there's a ton of things they have to do, right? Even to be a certified medical record, right? The old meaningful use accreditation. Like there's a lot that they have to do just to support clinical and patient accounting, let alone all the workflow optimizations. So it's where we kind of slot in nicely with that. That's going back to the cycles of healthcare technology in this wave of bring us best in class solutions that integrate seamlessly with our PM system. And that creates a really streamlined, smooth approach to your tech stack.
Yeah, which is fantastic. So that's a really great bridge to my unfair question for you, which is to tell me which is your favorite Rivet product. You have many, and I'd love to hear maybe one or two. I know it's unfair to say.
Oh man.
Who's your favorite
Yeah.
child?
Well, yeah, as I say, I have a 6-year-old, a 4-year-old, and a 1-year-old, and I guess it depends on the day sometimes.
I won't
But
ask you to pick a favorite between those. Yeah, of your
yeah.
software children, what's your
Yes.
favorite Rivet?
So we have 4. We have payer performance, which is around contract management, underpayment detection. We have patient pricing, which is around calculating patient out-of-pocket liability pre-service. Then we have claim resolution, which is what we were just talking about from both denied claims and unpaid claims. Things are starting to age out. And then our 4th is revenue diagnostics, which is around helping you forecast the difference between your gross and your net revenue, as well as your cash forecasting. So I would say our founding premise was around payer performance. And so it always has a near and dear kind of place in my heart that a lot of the independent providers feel like it's this David versus Goliath relationship as a provider versus a payer. And our goal with payer performance was to give them a platform that was savvier than the payer's platform, that had all the contract modeling tools and techniques, allow you to benchmark your data. Within the last couple of years, there's been an entirely new data source called transparency and coverage. That is literally, what is the market for reimbursement? What by tax ID, by NPI for all the major health plans? Says, what are the people getting paid? How do my rates compare to the markets? And that's all part of payer performance, is arming you as a provider to understand the health of your contracts, what's good, what's bad about them, helping you negotiate those, and then determine if you're expecting a certain reimbursement rate, are you getting that reimbursement rate? And those, we call payment variance, both from an underpayment, so you're leaving money on the table, and also from an overpayment standpoint, do you have a liability that you might have to report back to the payers? So that one, it was our founding premise. It's near and dear to my heart. And then the second probably being the newest of our products, which is revenue diagnostics, which takes, you generate a claim, an 837 goes out, but it goes out at $1,000 gross charge. It's just funny money, right? Unless you're a hospital or health system with a percent of charge contract, right? If you're a physician group, your charges, as long as they are at least high enough to cover the contracted rate, your charges are kind of funny money. And so taking that from what has been billed from a gross revenue standpoint and translating that into what is your net revenue and your cash expectations. So what does $1,000 bill mean? Is it $600 of revenue, $400? Does it vary based off of conditions that are met? Maybe it's modifiers, multiple procedure reductions, provider level discounts on the claim. How does that translate into real revenue? And then on the back end of it is when cash comes in, what is your realization against, we call it yield, on that net revenue? Are you collecting 95% plus of your net revenue?
Yeah.
So that's, I think it's a really cool product because typically the finance process to close a month, and if you're on an accrual-based accounting system, typically it takes anywhere from 5 to 10 days to close your month. That translates from 1 to 2 weeks to 5 to 10 minutes. You click a button, we've generated, we reconcile every 837. We assign a net value to it, a net revenue value. And then we say, this is the cash curve that we think you should be collecting on these different claims that have been billed out. So this is kind of a game changer from the FP&A and the financial side of healthcare.
Yeah, absolutely. I love it. Okay. Well, that was a wonderful rundown. Thank you. And that's a great thing to bring me to my last question for you, which is thinking about our audience of physician owners and administrators. What would you say are the top 1 or 2 most important things they should focus on in terms of their revenue cycle?
Yeah, two of the most impactful things, we've already talked about denials and we already talked about patient price estimation. The estimation that is a preventative measure to back end bad debt, right? It's very costly. I mean, the price of stamps keep going up, statement costs keep going up.
Yeah.
So if you can alleviate some back end costs by collecting a portion of, you should definitely already be collecting copays from patients. But if you have a good idea of what that patient is coming in for, maybe it's a level 3 E&M code, it's a surgical service, it's a diagnostic imaging where you have those radiology codes. If you can create an upfront estimate, not only do you improve the patient financial journey, but in many cases, you can collect at least a deposit or a down payment on that service which is doing a couple things. Primarily, you are increasing engagement from the patient. Less likely, if their total liability is going to be $1,000 and they've already paid, a $500 down payment, they're a lot less likely to be a no-show, no-call, no-show, last-minute cancellation, right? They have some skin in the game. So that alleviates some of your schedule, some of your optimization on, do we have gaps in our schedule all of a sudden that weren't planned for? But it creates lower back-end costs from collecting. So those are some of the financial things. And then just as a business, right? If our audience is physician owners, we look at, there's a lot of market tension, if you would, right now, where a lot of consolidation, there's a lot of private equity money coming into healthcare. Maybe it's not necessarily hospital acquisitions, but it could be, hey, we're going to group a bunch of independent practices with similar specialties and create a bigger network effect. And a lot of private equity dollars are coming into healthcare. Is, as a business owner and a physician owner, what do you ultimately want? What are your goals? Do you like the independence? Do you like affiliations? What is the company structure and the business structure? And then to be able to support that, what business objectives need to be met so that you can have that optionality, right? If you are a net negative operating margin as a physician group that's independent, it's only a matter of time until you're like, that employment offer from the local health system seems pretty attractive all of a sudden. So you setting your goals, aligning on those goals, and then determining what business objectives need to be met. And most of those are going to be fueled by revenue cycle. Are you bringing patients in the door? Do you have a full schedule? Are you billing things the right way? Are you capturing the cash and net revenue the way that you should? So revenue cycle can really supplement your business objectives and your goals and help you maintain that optionality that you get to call the shots. So it's kind of how I think about the relationship between revenue cycle allowing physician owners to maintain optionality.
Yeah, I like that. I like that notion of optionality, and just thinking about the very intelligent tools that you all have created. And I would reflect back, maybe it was the last question we talked about, but the contracting piece that you have. I know that we have a shared client, kind of a medium-sized group, that had negotiated a new contract with the plan a year or two prior, and that contract never got loaded at the payer. And so the payer continued paying them at the old rate. And when our shared
all the
client
time.
Plugged in your product, they found that was a six-figure check coming back to them. So, it sadly happens a lot. You can go through and do all the work to negotiate the new contracts, but following up and having a tool that helps follow up those kinds of things. So
I mean, you don't have the bandwidth and capacity to review every single EOB and remittance, right? If you just don't, you got to get things auto posted. You have to have some sort of reconciliation automation process when those remits come through. And you probably still have anywhere from 5 to 15% of paper checks and paper EOBs that you have to post. But you just it's so inefficient if you had to review every remit manually, especially if there's nothing wrong with it. And that's what systems are really good for. I mean, technology is great at doing that repeatable task over and over again and plugging in these large scale inputs and getting out a data model that says, hey, this is what we believe based off of all these conditions. This is what we believe that the allowable should be on that remit, and helping you flag and work those anytime there's a variance. So great call out, Jill.
Yeah, well, it's again a reflection of the quality of the products that you've created and the intelligence and the automation there for all the stuff that we really don't have time to deal with, but it's super important just in terms of getting that revenue in, getting the physician paid for what they've done. I say that a lot. I just want physicians to get paid for what they've done. Call me crazy.
What a novel concept.
I know, it really is. That's the whole concept here. So at any rate, well, Andrew, I can't thank you enough. I so appreciate the conversation today, and you're educating our audience even more about the technology that's available. And for everyone out there listening, we will drop the links into the show notes so that you'll be able to find Rivet Health and all the wonderful products they have. And Andrew, again, thank you for your time today.
My pleasure, Jill. Thanks for having me.
All right. Take care.
Bye.
Front Office Revenue Cycle Education, an in-depth course on the impact your front desk has on your clinic's bottom line. This online, on-demand 2-hour course is led by seasoned revenue cycle experts who will teach your front office staff the importance of obtaining accurate patient demographic information, how to effectively collect money at the front desk, and their impact on the life cycle of an insurance claim. Available now online for $195 per person at www.healtheps.com under Courses and Force. Enroll your front office staff and watch your denials go away.